Good morning. I'm presenting my work on combined femtosecond intrastromal lenticule implantation with cross-linking for keratoconus. I'm a consultant for AMO and Carl Zeiss. We all know that C3R is a proven modality to stop progression of keratoconus, but the visual and refractive results after C3R are not satisfactory, and most patients need glasses or contact lenses. So combined modalities with C3R have evolved, like topo-guided PRK, intrastromal rings, and phakic IOLs. They all have their advantages and drawbacks. We published a paper on cryopreservation of extracted corneal lenticules after SMILE and potential use in human subjects in hyperopia, and we thought we could use it for keratoconus. The purpose of the study is to describe an innovative technique of tissue addition and its clinical outcomes for keratoconus when combined with accelerated cross-linking. It was a prospective exploratory study, size of 6 patients, mean age of around 20 years. Inclusion criteria were mild to moderate keratoconus, evidence of progression, central cone, contact lens intolerance. We excluded eyes with advanced keratoconus, apical scarring, thin pachyes. After IRB approval and registration of trial, an informed consent was taken. A detailed pre-op evaluation was done. A cryopreserved lenticule was sourced from the Lenticule bank. These lenticules were collected from patients undergoing RELAX SMILE for myopia. After informed consent and serology, the lenticules were labeled and sent to cryobank in 20% phosphate buffer solution. We used a modified tissue processing technique for cryopreserving these lenticules in liquid nitrogen at minus 196 degrees centigrade. We matched the donor lenticule on the basis of spherical equivalent of the recipient eye. After ruling out axial myopia, after thawing and washing, a 3 mm corneal trephine was used to punch the center of the lenticule, creating a donut-shaped tissue. And this is how it's done, the central punching of the lenticule after we stain the lenticule with riboflavin. So you get a donut-shaped lenticule with a 3 mm central clear area. And then we make an intracorneal pocket with a femtosecond laser at 100 microns depth. We open up the pocket, and after that inject 0.25% Vibex extra, and with a soak time of about 1 minute, wash it out. Then we insert the donut-shaped lenticule into the pocket, center it to the pupillary axis, and subject it to UVA at 30 milliwatts for 3.3 minutes to give a total dose of 6.3 joules. Accelerated cross-linking. This was the mean follow-up of 6 months. Longest follow-up was more than 10 months, and all eyes improved in best-corrected vision from 2080 to 2040. There was a reduction in the mean cylinder, and you can see that the Q value also improved from an average of minus 1.61 to a more natural minus 0.55. No significant difference in endothelial cell density pre and post. No evidence of haze, infection, rejection. At the end of follow-up, this is the master chart, which showed that all eyes showed improvement in uncorrected visual acuity, while 4 eyes out of the 6 gained 2 or more lines of best-corrected visual acuity. There were no eyes which lost best-corrected visual acuity, which speaks about the safety of the procedure. These are the changes in topography, and you can see this is the pre-op and the 6 months post-op. You can see the central flattening. The spherical equivalent was minus 3.25, and the donor tissue implanted was a plus 3.25 diopter lenticule after myopic SMILE. The pre-op K reading reduced from 48 diopters to 44 diopters. The refraction improved, and the best-corrected vision also improved from 2080 to 2040. This was the post-op clinical picture, which showed a very clear, well-centered lenticule, and there was no shift in time. The AIOC2016 showed a demarcation line at around 200 microns, 3 months post-op. You can see that this is the improvement in asphericity in one of the cases from minus 1.13 hyperprolate cornea to a more natural 0.19 Q value. There was also an improvement in higher order aberrations as measured with the eye trace, in this case 1.51 to 0.67, and the point spread function improved. This is the corneal biomechanics with the CORVIS, also showed an improvement in the deformation amplitude pre-op from 1.21 to 1.19. This is how it works. With keratoconus, you have a central steep area and a flatter mid-peripheral part. When you put in a donut-shaped lenticule, there is a steepening in the mid-peripheral part and a relative flattening in the center, and that improves the shape, and then you do the cross-linking to freeze the cornea. The limitations are that you can treat only central cones on topography, mild to moderate keratoconus. Results may be unpredictable in advanced cases with eccentric cones, and the nomograms have to be refined. To conclude, combined Philly with cross-linking appears to be a feasible option to treat keratoconus. It potentially improves quality of vision by improving the corneal shape, reducing abrasions, no risk of extrusions or infections like rings, low risk of rejection. It is a reversible procedure, but we need, however, long-term follow-ups to establish the long-term safety, efficacy, and effects on corneal stabilization. Thank you very much for your attention.